back to a slide that everyone should be pretty comfortable with by now. A couple of the things I'll pull out about that are exceptional about dental health in rural areas are the lack of fluoridation. So people in rural areas are more likely to be on private wells, and that's less likely to be fluoridated. Along with the insurance rates that we saw earlier about medical and employer-sponsored insurance especially, there's less likely to have dental insurance for the same reasons. And we have shortages or maybe maldistribution of health providers as well in rural areas. So I'm going to talk a little bit about Missouri, and I'll start here with some of the data problems that I wanted to talk about. There are a lot of really great health data resource websites out there. The Behavioral Risk Factor Surveillance System has a nice thing where you can pull out state-based estimates and things like that. The issue comes when you want to actually look at rural-urban differences, and especially if you want to drill down into different levels of rurality, like rural and frontier and whatnot. And so that's why I think one of the messages that you've gotten all day is that you probably need to make some friends who are at some of the rural resource centers, or people who are doing rural health research to really drill down to that kind of level of detail. But there are a lot of very good studies out there that do take these types of data and get it down to some pretty granular data. So you'll notice 31% of the you'll notice that generally speaking, in some things Missouri doesn't do as well as the general population of the U.S. and some things they're better. Adults are slightly less likely to have a dental visit in the last year. They're pretty significantly more likely to have complete tooth loss and to lose some of their teeth. But the good news is children are a little less likely to have untreated tooth decay in 3rd grade, and you have a lot more fluoridation in Missouri. They're pretty close to the Healthy People 2010 goal of fluoridation across the U.S. And to put a context around this, about 31% of the population live in rural areas in Missouri, and nationwide it's about 21%. So this is a fairly rural state. And this slide is interesting to me. It was done in 2004, and I thought the data were interesting. And I think you can look at the private side, and it's probably more or less correct. People are, this is sort of auxiliary types of insurance that you might get as part of your insurance package. People are much more likely to have drug benefits than they are to have oral health benefits, but then we're better off than folks who need vision care. If you look on the public side, the reason why I think that this is not accurate anymore is in 2005, Missouri cut their Medicaid dental benefit for adults. So basically the only people covered by public programs right now are children in the state of Missouri, and that's pretty common across the country. 69% of children in rural Missouri have dental insurance compared to 80% of urban children. And again, to kind of talk a little bit about what do you get when you have a dental insurance plan? Generally speaking, you have really good preventive care. They'll cover 1 or 2 visits almost completely or with slight copay. You tend to have often pretty substantial cost sharing for anything besides preventive care. So it's a form of insurance. Oh my God. I don't have any idea what that is. I don't know how to do that. I know I didn't do that. So I want to talk more about the low-income folks, the folks on Medicaid, and also uninsured folks, and how do they access dental care. So if they're children and they're covered by Medicaid or CHIP, they can try to find a dental provider who provides care, and that's actually very difficult to do. I believe something like nationwide, only about 16% of dentists have a substantial Medicaid population in their covered groups. And the reasons dentists give are low reimbursement rates, and Medicaid tends to reimburse at about 1/2 to 1/3 of a dentist's usual fee, while private insurance, as a contrast, tends to reimburse at about 80%. Another complaint is administrative burden. There are forms that have to be filled out. A large one that's kind of unique is that they complain about missed appointments, and they call it sort of the cultural interaction with Medicaid beneficiaries. And if you think about some of the issues, life can be very chaotic for people on Medicaid. People tend to go on and off of Medicaid. They often have housing issues as well, so they may be moving around so you don't get mail as conveniently. There have been, for the good news, there have been a lot of pilot programs across the country trying to come up with ways to case manage Medicaid beneficiaries to ensure that they get to their appointments. There's some great programs that provide transportation assistance to get folks to their appointments. So I think there's a lot of work on that side, but it is still a concern for dentists. Another concern is that folks on Medicaid have really bad teeth compared, or uninsured folks have really bad teeth compared to the general population, especially the privately insured population. Again, going to David's article, he talked to this gentleman, Mr. Homerding, and Mr. Homerding's teeth started breaking off 3 years ago, and he couldn't find a dentist for a while who would see him. He finally found someone who would give him an appointment, but, quote, he took one look at me, said, "I can't help you," and walked out the door. Because you're talking about the huge investment of time at relatively low reimbursement rates, and this was before you would have any kind of change. So I think that's sort of an issue about that population and that profession. I wanted to talk a little bit about emergency departments. Some of the work that I did was on emergency department use for oral health complaints in rural and urban areas. And basically, if you go to the emergency department for tooth problems, they can give you painkillers, they tend to refer you to a dentist, and very occasionally they'll do extractions, but they seldom have a dentist on call to actually fix your teeth, so it doesn't tend to solve any problems that you have. In the study I conducted with a colleague, we looked at, we found that states with more generous Medicaid dental benefits tended to act more like privately insured patients in terms of their care-seeking behavior in EDs, while states with less generous Medicaid benefits tended to act more like uninsured people in EDs. And unlike the rest of most studies on ED use, where privately insured folks are more likely to use the ED than uninsured folks, in oral health complaints, privately insured folks don't go to the ED for oral health concerns. They go to their dentist. Okay. So I'm leaving off this discussion of federally qualified health centers because we have someone here to talk knowledgeably about that, which is great. I wanted to move on quickly to one of the issues is thinking about oral health in the context of a medical home, or trying to get folks to places where they come back regularly and they know where they're going and who they're going to see. And in the context of rural areas and provider shortages, there are a lot of really interesting new programs that are coming out, including expanding scope of practice for dental hygienists, so that either they can practice without a dentist observing them, or else even they can bill Medicaid, which would be great, and that would be mostly for preventive care. The Alaskan Dental Health Aid Therapist Program has been very successful, where they train community members to go up and do everything from cleanings to sealants, and to then refer folks when they have serious complaints. Minnesota dental therapists are kind of the same, a slightly different model. There's more education involved in the Minnesota program, but they can also bill Medicaid. And then the ADA has come out with a community dental health coordinators program that they're piloting right now in several urban and also rural areas, where they're trying to train community members to do a lot more of sort of the care management. They can look at people's teeth, they get a general idea of how they're doing, and then they refer them to an FQHC or a rural health clinic. Another great source of potential care is school-based clinics. You get a lot of low-income students in one place. They go there regularly, so you can develop a relationship in that way, and that's a very efficient way to provide care. And then a third that I'm pretty excited about are some of the technological solutions. And one of the cases is the Marshfield Clinic in Wisconsin added a dental component to their clinic, and now they're merging the dental health records with the electronic health records, so that doctors and dentists have a full view of what folks are doing. And my hope is that this will make doctors say, "Hey, how are your teeth doing?" and have dentists more involved in the rest of people's care, so that you kind of get rid of some of that schism. The other issue that I think is really interesting is the changing dynamics in rural areas that we talked about earlier, the changing demographics, and the issues for teeth, because you do have a lot of folks from Mexico didn't have any dental care and don't know how to use that system, and so there's going to be a lot of behavior change and learning and health education that will need to be done there, which sounds like more of a role for some sort of a community health worker kind of role.